Our third speaker for today's webinar is Dr. Daniele Santi. Dr. Daniele Santi graduated with honors from the University of Modena in Reggio Emilia, Italy in 2008. He went on to specialize in endocrinology and metabolism, graduating with honors in 2014 and completed his PhD in clinical and experimental medicine in 2017 at the same university. Currently, Dr. Santi serves as an associate professor at the Unit of Endocrinology, Department of Biomedical, Metabolic, and Neural Sciences at the University of Modena in Reggio Emilia. He has authored numerous scientific publications in high-impact peer-reviewed journals, primarily focusing on endocrinology, andrology, and reproductive medicine. In 2015, he received the ESE Young Investigator Award. Dr. Santi is also an active member of the scientific community, serving as a reviewer and editorial board member for leading journals. He is currently the General Secretary and a member of the Executive Committee of the Italian Society of Medical Andrology and Sexual Medicine SIAMS. And Dr. Santi will give us an insight into the semen analysis, when it is needed, and how to interpret the results. Dr. Santi, the stage is yours.
Thank you, Christina. So we look at the other side of the medal, since we talked about testosterone and hypogonadism, and now we change to semen analysis. And I try to give some points that I think are relevant for clinical purpose, mainly considering semen analysis. And so when and how better should be interpret semen analysis. Just to start talking about semen analysis, we have to remember that now we have many guidelines available from many scientific societies that should help us in the management of male infertility. I have not to explain the relevance to evaluate the male partner of an infertile couple, but it is very important to remember that this should be stressed also in other settings, and in particular in assisted reproduction. And obviously, semen analysis is still the gold standard for the evaluation of the male fertility. And however, we have to consider that semen analysis is not our ending point during the diagnostic workup, but just the starting point. Is one of the steps that we have to perform during the diagnostic workup. And so semen analysis must be considered together with other points, such as the obviously medical history collection, the physical examination, and the evaluation mainly of the hypothalamic pituitary gonadal axis, since the testis is just one of the step in this endocrine axis. And so it is very important to consider all the axes and not only the sperm production, and so the semen analysis. When it should be considered, the answer could be probably also complex. This is just an example. This is a flow chart that you could find in the guideline published by the Italian Society of Andrology and Sexual Medicine 2 years ago, in which there are reported all steps that we have to do to evaluate the male partner of an infertile couple. And you see that semen analysis is for sure one of these steps, but it is not the only one. And this is important to remember during our work, especially in clinical practice. And the second point that we have to consider is the complexity of these parameters, because you know that the WHO established which are the methods to perform the semen analysis and how to interpret the semen analysis. And we have a manual that explains this point, and so it is not a simple examination. We have 6 different editions. The last one was published in 2021, and this is the 6th edition of the manual that give us some changes or novelty in the interpretation of the semen analysis. I think that the most relevant point that we have to remember considering the semen analysis are this 4 that I will try to give an overview. First of all, the parameters that we can evaluate with semen analysis, conventional semen analysis. This is just an example of the result of a semen analysis. And you know that semen analysis give us many parameters from what concern the sperm quantity, so the sperm concentration, total sperm count, and the sperm quality, at least from a microscopic point of view, so the sperm motility and the morphology. The motility in the last edition was changed again, and now the guidelines suggested to give us information about fast progressive motility, low progressive motility, non-progressive motility, and motile sperm. This is obviously a source of variability among laboratories, because not all laboratories that we can use clinically report the examination with this information. But the most important point to remember is that none of these parameters are able to give us information about the real competence of the sperm. And the competence is the ability of the sperm to fecundate the oocyte. This information is not provided by these parameters that are provided by conventional semen analysis. The manual gives us also other endpoints. One is the sperm DNA fragmentation index that will be evaluated later by Liliana, and that for sure provide more information for the real quality and the competence of the sperm. But remaining on the conventional semen analysis, so the conventional parameters that we have to consider, in the literature, there are many trials or manuscripts that try to compare the parameters and try to find the best parameter in order to predict the final response. And in terms of fertility, obviously the response is the pregnancy. This is a recent work, is a longitudinal cohort study, very large, with more than 6,000 men, infertile men. And the author performed this longitudinal analysis to evaluate if one of the semen analysis parameters are really able to predict the pregnancy. The result is that no one of these parameters are really able to predict the pregnancy, but there is a correlation with the time to pregnancy, time to conception, in terms of spontaneous pregnancy. So there is no direct correlation with the pregnancy, but with the time required to obtain a pregnancy. So some kind of indirect relationship. And in particular, they define the total sperm number as the best parameter provided by the conventional semen analysis in order to predict this time to conceive, representing the sperm production from one side, and also the activity of other glands, such as prostate, with the semen volume, since the total sperm count is just the multiplication of sperm concentration and semen volume. We recently produced this work evaluating more than 20,000 cycles of assisted reproduction. And we tried to do the same. So we tried to find whether a parameter in the semen analysis is able to predict the pregnancy rate in the setting of assisted reproduction. And we, considering this large cohort, detected that among parameters available, the progressive motility is predicting the final pregnancy rate in IVF cycle, and the normal sperm morphology predicts the pregnancy rate in ICSI cycle, suggesting that it is true that some of these parameters could really predict the final pregnancy and the final success of the couple. So far, we are not able to define which parameter should be the best parameter to evaluate the fertility of our patient. The second point to remember is the high variability of semen analysis, since it is largely demonstrated that the semen analysis in the same patient could be very different. And this is the reason why the WHO recommend to perform at least 2 semen analyses to have an idea of the real fertility or potential fertility of our patient. This is probably the best explanation. This is an old study published in 1991. This is a single patient of proven fertility that perform semen analysis every 2 weeks for more than 6 years. And you could see in the figure sperm count, semen volume, and sperm motility. And if you look at the figures, there is an high variability of these parameters comparing each examination. If we look at the sperm count, we have sometimes a sperm count near to 300 million and sometimes near to 0. So there is an extreme variability that obviously reduce the accuracy of this analysis, but must be considered from our side in front of a man that are evaluated for male infertility. The third point to keep in mind is the use of reference ranges, because we are generally we consider each parameter with a reference range, normal and abnormal. The manual provides us some ranges for all parameters, so for sperm concentration, total sperm number, and so on. This is the table resuming these ranges from the first manual edition in 1918 to the last one. Some kind of difference. These data are obtained considering a large cohort of men with proven fertility, more than 3,000, that performed a semen analysis. The distribution of data was evaluated, and this range is the 5th decile of data distribution. So it is clear that this range is not able to clearly discriminate between fertile and infertile men, since at least the 5% of this large cohort obtain a pregnancy despite a value below this range. And this is the reason why, and this is probably the most relevant innovation of the last edition of the manual, is that this limit must not be considered as reference range, but just decision limit. This means that we cannot use to classify the patient, to define if the patient is infertile or not, but just to help the clinician in the decision, so to take to start a treatment or to monitor the treatment, but it is not able to really classify the patient. And this is the last point to be considered. So the terminology derived from semen analysis, since we generally use these terms in our clinical practice. So the term oligozoospermia when we have low sperm concentration or low total sperm number, astenozoospermia when we have a reduced motility, teratozoospermia reduced normal morphology. This is obviously these are categories that could be useful, but the manual suggests not to use these in clinical practice, because since the semen analysis is not able to discriminate between infertile and fertile, we cannot use this range to create a fixed category of fertility or infertility. And so these are categories very useful, at least on research practice. And this is the reason why 2 years ago was published this position statement on andrology that tried to give a sort of checklist for studies that should be published involving semen analysis, reporting all steps that we have to follow in research practice to describe our work, to describe how semen analysis was performed, and in order to create a reliability of the study and create and confirm the performance of the study, of the semen analysis. So just in conclusion, few take-home messages, because I think it's very important to remember that male infertility is complex to be evaluated, and the semen analysis is a step in this setting, but it is just a piece of this complex clinical situation, and that we have a manual that help the definition, the interpretation of the result of the semen analysis, but these data are must be considered carefully, considering that we cannot discriminate between fertile and infertile. Although this is known, that is the only parameter, the real gold standard so far to evaluate the potential male fertility. Thank you for your attention.
Dear Dr. Santi, thank you very much for this highly important and insightful talk. Now going back to Eleni and for her to introduce our fourth speaker.